And let me know if you see the PowerPoint.
Yes.
Excellent. All right, so again, this is HIV in the year 2021, ending the epidemic. I'm Dr. Doris Russ, the medical director at AHF, which stands for AIDS Healthcare Foundation in Jacksonville, Florida. And I just look forward to answering your questions, getting started. If you want to put questions in the chat throughout, that's perfectly fine. And we'll get started. I do have a few one financial disclosure. I own shares of Gilead, and that is one of the companies that is searching for a cure for HIV. So I want them to put me out of business, and I can't wait. Tonight's objectives will be to define HIV and AIDS, examine current statistics and trends, review treatment options, review prevention options, examine the relationship between COVID-19 and HIV, and then contemplate potential areas for HIV advocacy. HIV stands for human immunodeficiency virus. What makes this virus unique? It's one of two viruses that affect humans that are actually retroviruses. What that means is that they incorporate themselves into the host cell's machinery to actually copy itself. So there's HIV 1 and 2, and then there's HLTV 1 and 2. So those are the two classes of viruses that are retroviruses. Ultimately, it attacks the immune system. So that's what makes HIV and especially AIDS so dangerous. It's not so much that somebody has the virus, it's that they're not able to protect themselves against opportunistic infections. What I have here is a picture of the basic cell of an HIV cell, and it'll be important later when we talk about treatment so you can understand how the different treatments work. So you have your envelope, which is of course the case for it. You have the capsid, which then encloses the HIV RNA. You have the enzymes that make the cell work, and then you have glycoproteins, which are how it attaches to the human cells. Modes of transmission include any form of sexual activity, intravenous drug use, perinatal or mother-to-child transmission, and occupational. Perinatal is much, much less common here in the United States than it used to be, but it is still important that pregnant women are screened during pregnancy so that if they do test positive, they're able to start treatment. It's the treatment that they take during pregnancy that prevents the transmission. Who's at risk? Anyone who engaged in the above mentioned activities. In particular, men who have sex with men and transgender are two of the populations that I work most closely with. I'd like to take a minute to talk about how, as a society, we should aspire to be more inclusive and welcoming. I did invite some of my patients to speak tonight, and they did not want to out of fear for being outed, either for being HIV positive or for being transgender. So I think the closer we get to accepting everybody, the better off we'll all be. Society is richer when we're able to learn from one another. Adolescents, mainly because they engage in risky behavior and are not fully aware of the consequences. The elderly, possibly because when they were younger, the biggest consequence of unprotected sex was pregnancy. So now that that's off the table, they do engage in unprotected sex and they're at risk for contracting HIV. There's a common name called condominium Casanovas. So when people move into the retirement homes, they may engage in each other's company, but so it's very important that we counsel them on protection as well. Heterosexuals and those engaged in substance abuse. The current recommendation is that everyone aged 13 to 64 have at least one HIV test in their lifetime. My thought is if you're engaged in any of these activities, the safest bet is to have one at least once a year. AIDS actually stands for acquired immune deficiency syndrome. So not everyone that has HIV has AIDS. So if you think about it, SARS-CoV-2 is the virus that causes COVID. HIV is the virus that causes acquired immune deficiency syndrome. There are two ways that a patient can be diagnosed with this. If their CD4 count is less than 200, and CD4 count is the type of white blood cell that the virus attacks, it's what we mark to see how well the patient is doing. Or even if they have a high CD4 count, if they have any of the illnesses listed on this screen, which we call opportunistic infections, that also would constitute a diagnosis of AIDS. Quite commonly, it used to be called PCP pneumonia, pneumocystis jirovecii pneumonia, so now it's PJP is one that we see a lot, unfortunately. Tuberculosis, some different virus or bacterium that affect the brain as well. And then Kaposi sarcoma. So for those of you who remember the beginning of the HIV crisis, it was men presenting with these unique types of cancers, and that's Kaposi sarcoma, which is curable, by the way. So let's talk about the scope of HIV and how it's impacted this country. So as of 2018, from the start of the pandemic, or epidemic, excuse me, until 2018, about 700,000 people had died from HIV/AIDS, which when you think about the 592,000 people that have died from COVID in the past 14 months in this country, it starts to put things in perspective. It allows for discussions about priorities and resource allocation. Almost 13,000 people will die from AIDS every year, which is even more unfortunate now because of the treatment options we have. But the problem is, and this just is why testing is so important, 1 out of every 7 people that have HIV don't even know they have HIV. So not only are they at risk because they're not taking medication, they're also potentially spreading it as well. And just for completion's sake, about 1.2 million people had HIV in this country at the end of 2018. There's always a lag between when the data is released and when we're able to talk about it. So that's why it's year end 2018. Any questions? Okay. So then we'll talk about HIV incidence and HIV prevalence. So HIV incidence is the number of new cases. And again, this is for year 2018. You can see our beloved state of Florida is, right there in the top, leading the pack with that gorgeous deep purple color. Part of that's because we test, so we are able to diagnose. Part of it's because we're at a very attractive location, so we end up getting a lot of people from either other states or even other countries that have it. But part of it's also because we need to do a better job with prevention and awareness. And similarly, when we look at HIV prevalence, which stands for the total number of cases, you can see again, we're that rich purple color in the state of Florida for the reasons we mentioned beforehand. What are the trends? So the good news is the number of diagnoses are actually decreasing. If you look at the general population, it went down amongst Black and Latinx persons as well. The problem is both of those groups are overrepresented compared to their percentage of the population. Again, to take a look at Florida for the previous decade, you can see the number of new cases per year of HIV. So it looked like we were actually making a lot of headway in the early 2000s, and then that trend kind of reversed itself and started to spike. Given the social isolation and all of the things that we've been through in the past year, it'll be interesting to see where the numbers go for 2020, 2021, and 2022 as well. Prognosis. So I always tell my patients, I know exactly how you feel about HIV based on how old you are. For those 40 and above with a new diagnosis, they think it's a death sentence. For those under, we'll say 25, they say, give me my medication, I'll be fine. And the truth is, it really can be either one. If patients take their medications, they work, they are life-saving, life-sustaining, and they can be dancing and celebrating and enjoying life. What's awful to see is when someone, makes the decision, well-informed decision not to take the medications, and you see the slow decline and eventual demise of those patients. And then if someone's between the age of 25 and 40, it's just kind of a toss-up depending on what their personal experience or knowledge of the virus has been. What I will say, and this is especially important for youth, even though we have great medications and people are living normal lives, engaged in all the activities they would have otherwise, someone newly diagnosed today will still lose about 10 years off their total life expectancy due to this disease. So that is something to keep in mind. As great as the treatment options are, as great as prevention is, we have to keep in mind that this is still a very, very serious disease. So then we talk about treatment. So again, depending on how familiar you are with HIV, you may remember when there were no treatments, and unfortunately HIV very much was a death sentence. And then medications came out and people signed up to be in trials, and they put their bodies through whatever because that was the only chance or shot at survival. There were the infamous drug cocktails, people taking upwards of 30, 32 different pills a day. They had to take them at the exact same time so that they didn't develop resistance. And it was stressful. There were a lot of side effects. Even today with our long-term survivors, we see side effects with problems with the kidneys, possibly problems with bone density. So it wasn't a walk in the park, but at the time it was all they had. So it was better than nothing. This picture just kind of represents where we started. I mentioned earlier that we were going to talk about the different parts of the cell. So there are different classes of HIV medication. So every medication works in multiple ways. So it works on some part of the cell, whether it's to keep the virus from being able to actually integrate into the host cell, or if it's to keep it from replicating or even attaching. So this just kind of is the follow-up to the previous slide. Now we can talk about the advances in HIV, and this is where I get very excited. So you have Dovato, which is a very popular HIV pill, and it is not made by Gilead. I chose that on purpose. It's actually made by V. It is a once daily medication. I know they've advertised this medication at the Super Bowl, the Grammys. I've seen it on a couple of soap operas, which I think is amazing to see how mainstream discussion of this virus has come. It consists of 2 medications, but it's once a day. People take their medication and they go on about their lives. What's very exciting, on the other side, you can see that you have 2 vials, and this is actually a medication that was approved by the FDA this year for treatment. So it's a once a month injectable medication for HIV. A lot of times people might not take their medications because of the side effects of nausea. They might not want anybody else to know they have it, so they're hiding it. Apparently people still go through people's medicine cabinets. I thought that was just on TV, but it's real. So this is an option for the patient to get their shot once a month, be treated. It's no one else's business, and they can continue on with their life. So that is brand new. Great research studies on the efficacy. So we're very excited about that as well. And if anybody wants to look it up or tell someone that they know, it's called Cabenuva, also not by Gilead. So this is where I'd like to get a little interactive if we can. So I gave you a hint. How can we prevent HIV? I want to know if anyone else has any thoughts about things that we can do. And I don't know if there's anything in the chat because I'm in a different view. If there aren't, we'll keep going on and we'll come back and circle for questions later. So again, the 2 most common things people talk about when it comes to sexually transmitted HIV, they talk about using condoms, which are very important. And then there's also a sect of the population that believes discussing abstinence and preaching abstinence is the other alternative. And again, if you are 100% abstinent, it is a great way to prevent HIV, but I live in the real world and I want to make sure that my patients have options. So some of those options include, we love acronyms in this world. So it's PEP, PrEP, and U equals U. I should make a cheer from that. So we're going to talk about each one of these in turn, and you're going to know just how far we've come. So PEP stands for pre-exposure prophylaxis, and there are 2 different forms, occupational and non-occupational. So for example, if a healthcare worker has a needle stick, they get tested, they start medication right away, and that blocks the transmission of HIV. For someone that has non-occupational exposure, whether it be someone that had unprotected intercourse or someone, unfortunately, that was sexually assaulted, they can take PEP as well. They take medication for a month and they're tested for several months thereafter to make sure their status remains HIV negative. So again, those are one of the tools in the toolbox. This is not intended for routine use. If you're going to be engaging in intercourse with someone that is HIV positive, we recommend PrEP, which stands for pre-exposure prophylaxis. This came onto the market about 2011, 2012. It is an antiretroviral medication. So it is a medication that the patient would use for HIV treatment, but it's not a complete regimen. There are 2 different ways that you can do it. The FDA has only approved the daily regimen, so taking the medication every day. There are some people that will take it off label in the 2-1-1 format, which is 2 to 24 hours before having sex, you take 2 pills. 24 hours later, you take another pill, and 24 hours after that, you take the 4th and final pill. Again, the only thing that's been shown to be fully effective is the daily treatment. And if somebody decides to be on PrEP, the next part of their care is they actually come in for labs every 3 months to make sure they haven't converted. It's very important that if someone does become HIV positive, let's say they miss a pill on a day, that we get them on a complete regimen. Otherwise, they risk developing resistance to the entire class of medications. And then we have U equals U, which I think it's just, I love saying it. I have a U equals U t-shirt. I debated wearing that today, but I decided to dress like an adult. U equals U stands for undetectable equals untransmittable. And this represents the proven fact that a person living with HIV who remains on their medication for at least 6 months cannot transmit the virus via sexual activity. So what this means is taking medication doesn't only treat your HIV, it prevents you from being a vector for spreading it to someone else. So it's also a matter of prevention. This is one of the biggest developments in the HIV world in the last 5 years. It's not really publicized or talked about, so that's why I'm so glad I get to come before you this evening to talk about it. I think it's another reason why we should encourage everyone to get tested. You know your status. If you're positive, you can get on treatment and then you can protect your loved ones as well. Any questions at this point?
Yes, doctor. I'd like to go back to this slide that showed the, you don't have to actually.
I'll go back. Which one?
The one that shows the downtrend and then coming back up again. And I'm just curious as to what, yes, so it dropped all the way down to what, 43.50 or something?
Yeah.
2013, and then all of a sudden it came back up worse than 2010. What were the causes of that?
So the theories behind this are, we've done such a good job at saying HIV is treatable and you can lead a normal life that people do not fear it as much as they used to. So there's been some return to previous behaviors. Again, you have a whole generation of adults, like not just yet, like adults that don't remember what it was like to see celebrities dying from AIDS, and that would be what was on the Today Show. I remember there was Rock Hudson, you had Arthur Ashe, so it's a different mindset. I think it's great that we have the advances that we have, but it's also important to make sure we balance that with routine education and promotion of what's out there. And then you have to look at what's going on in terms of the government and policy, and we'll talk more about that in a minute. But 2013, 2014 was the year where we had the actual official rollout of Obamacare. But Florida didn't expand Medicaid, so that's always a possibility of a lost opportunity. What is so great is there are plenty of federal programs that fund HIV care and treatment. Thank you, it's how I have a job, so I'm very thankful. So that even though medication costs anywhere from $30,000 to $40,000 a year for a year of HIV treatment, patients are able to get it regardless of their ability to pay. But they have to get tested. The other thing that's changed, again, we talked about how it's not as scary as it used to be. There's also just society has changed. You're going to hear songs on the radio that you never would have heard, not even 20 years ago or 30 years ago, which promote a different lifestyle. So we want to make sure that people are aware, are informed, and are getting tested. Again, my company tests every Wednesday and Saturday. The health department tests every day of the week. You can get an HIV test and know your status. And again, you're protecting yourself and your loved ones. Great question.
Thank you.
Anyone else? If not, I'm going to try to get back. And then we talk about HIV and COVID, and I just am amazed. They always say if you don't learn from your history, you're doomed to repeat it again. And the parallels between the beginning of the HIV crisis and COVID are undeniable. So again, there was a mishandling from the government. So if you're of a certain age, or if you've ever watched any of the movies that talk about the early days of the epidemic, the White House did not talk about this disease. You have press conferences where reporters would ask, and it would be a joke, why do you need to know that? Is that something that applies to you? If not, we're going to continue on with the conversation. So definitely a lack of information, which unfortunately led to people dying because the dollars weren't committed to research at that time. We can compare that to last year with all of the mixed messages that came out about COVID. Wear a mask, don't wear a mask, 6 feet, 3 feet. It is transmissible by air. It is transmissible by air. And that was a valuable time where we lost the public's trust, and we lost time in getting ahead of the disease. And we've seen and suffered the consequences from that. Both of them had stigma again. And I'll say this for completion's sake. In the early days, they said that there were only a few groups of people that had to be worried about HIV, and they would categorize it as the 4 H's, which would be homosexuals, hemophiliacs, heroin or IV drug users, and Haitians. And that was so not looking at the total picture, and it wasn't accurate. Like, those were the groups most at risk. And if anybody's wondering, it wasn't that Haitians overall were most at risk. It was Haitians that were men having sex with men. So they really were in another category. They were just miscategorized. And so it was stigmatized. If anybody's ever heard the story of Ryan White, he was a young hemophiliac who, through a blood transfusion, contracted HIV. And he was actually had to leave his school because there was such an outcry from the community. Instead of embracing this child, people shunned him. Part of it, again, was lack of knowledge, but part of it is just when you see the worst in humanity. Fast forward to 2020, when people were like, how did you get COVID? You must have been irresponsible. You were at a party. Whether or not you were a part of an essential worker who had to work, or you don't even know where you were exposed. So both of them were stigmatized. And it's just amazing how within one lifetime, you're seeing the same thing happen again. And the saddest part is that both of them now, with the knowledge we have, are preventable. So with HIV, I like to say we have a toolbox. I don't recommend that you do any one thing. I recommend you do a conglomerate of what works best for you. So we have abstinence or condoms. We have PEP if needed. We have PrEP. We have U equals U. So when you put all of those tools together, it's almost impossible to transmit HIV. But you have to know about them and you have to use them. Same thing with COVID. I know everyone is sick of me talking about wear your mask, wash your hands, and socially distance, but it has been proven to be effective. And the vaccine is effective at preventing 70 to 95% preventing serious disease from COVID, and 100% against preventing death from COVID. So the vaccine does its job. So that is where we are now. For me, getting to the vaccine was the goalpost for COVID. So we've gotten there. Now it's just a matter of making sure everyone knows where they can get it and get it if they so choose. So in terms of HIV and COVID, initially people were really excited. They're like, we're already on these antiviral medications. Maybe it will protect us from COVID. There were a few older HIV medications that they tried to use in studies to see if they would fight COVID. Unfortunately, they did not. What we have learned, a normal CD4 count are not at any increased risk of complication from COVID. Those living with a CD4 count under 200 are at increased risk of having serious complications from COVID. The vaccine is recommended for people with HIV. We had a few that were in the trials. We want all of our patients immunized because COVID is very much still out there. There are over 25 variants, and it's a race against time. So we're going to see what happens if we reach herd immunity or if we don't. But it's important to protect yourself and your loved ones. And what I think is really cool is that the research used for some of the COVID vaccines, so Moderna and Pfizer, which would be the mRNA, are actually now being studied for HIV, but actually for cure, not just for treatment, but possible HIV cure. So I do hope to see that in my lifetime as well. And then we'll spend a few minutes talking about advocacy, and some of these are controversial, and it's just one of those things you have to think about. The science is advancing, so the law should keep up as well. So I'm not arguing for or against, I'm just letting you know where you could do further research or things to think about. So part of HIV in Florida is there's a duty to disclose your status. So before you start a sexual relationship, if you know that you have HIV, you have to disclose your status to your new sexual partner. Failure to do so can lead to prosecution of up to a third-degree felony. Okay, so 20 years ago, this made sense. You want people to know if they're potentially exposing themselves to a lifelong disease. But now we know how many different ways you can prevent it. I'm not saying you should disclose or not disclose, but I think that's something that needs to be followed up. The issue with the disclosure statutes are in our state and states across the country that have them, they disproportionately are used against people of color. So that's where we get into the whole overrepresentation in the courts and in the criminal justice system. So that's an area for talking. And then we also have possible decriminalization of sex work, which becomes a very, very challenging topic because the issue of human trafficking, are people doing this because of a choice? Are they being forced? You're just never sure. But for those who willingly engage in sex work, which a lot of our patients, not a lot of our patients, but a lot of people in this community do, because they are shunned and shut out of different career opportunities. You know, Jacksonville struggled for a long time to pass the human rights ordinance. I'm so sorry. So we have different options. So sometimes they turn to sex work, but you don't want them to be penalized in the middle of trying to provide a living for themselves. One of the things that everyone can advocate for is comprehensive sexual education. There's nothing sadder than having an 18-year-old say, I didn't know, and they're newly diagnosed with HIV. So that's another option. And then safe needle exchanges. So PEP is great and PrEP is great, but those apply to sexual encounters. So for those people that are using IV drug use, some states have safe needle exchange programs, so they're not at risk from that mode of transmission. I'm going to pause and ask if there are any questions at this time.
I actually do have a question.
Sure.
So we've discussed the similarities between the HIV and the COVID-19 viruses and how the government mismanagement has led to the stigmatization and demonization, I would say, of the illnesses and their treatments. Now that the vaccinations are all underway for COVID-19, and we know that the vaccine is recommended for those with HIV, do you think that there is enough effort getting shots into arms for people affected with those diseases? And are we still seeing any hesitancy among them because of the social stigma?
Oh, what a great question. So it feels like many moons ago. Turns out it was only 2 months ago when people were arguing, there's not a problem with hesitancy, it's only a problem with access. I said, no, you have to address both issues because both of them are problems. So to answer your question, what we have seen is that patients that wanted this vaccine were knocking down our doors when we started offering it. When the state of Florida made it one of the conditions that made somebody medically vulnerable and they could get it, people got letters in droves and they got the vaccine. Now what we have are patients that want to wait and see what the vaccine will do. They are suspicious. And I understand that there have been a lot of circumstances and occasions in this country's history where there are reasons to be distrustful. So I understand the why. What I don't understand is now that we have the data, we've shown that it's safe, I don't understand the continued hesitancy. And so I like to pretend I'm the game show host when I have patients come in and they don't want to get the vaccine. So I say, how many people in America do you think have received at least one dose? And they give me a number and they say, whatever the number is. And I'm like, actually, it's 149 million. And they're like, what? But I thought, and so it puts it into focus. Other things that we do to get people to know about the importance of the vaccine, we talk about the safety. I'm very transparent with my experience. I got Moderna and the second dose wasn't easy, but it was worth it. We talk about the risk of the variants, how we don't know what's next. And what I love to say is you don't know what the vaccine will do to your body in 5 years. We don't know what the virus will do to your body in 5 years. So in medicine, you have some diseases that you get and then they represent later on. So for example, the most common example is people who have chickenpox as a child are at greater risk of having shingles as an adult. So we don't know what kind of effects this virus will have long-term on the body. And we're already now seeing the long hauler syndrome. So we recommend it for all of our patients. Sometimes it's just a matter of having that conversation. In terms of the rollout for people in healthcare, we're like, it's not that hard to get a vaccine out. We do annual flu vaccine drives every year. So we were a little dismayed to see how the rollout went, but we're happy now that everyone can get it. I do want to do a quick plug for anyone that's looking for the vaccine. You can either go to vaccinefinder.org or vaccines.gov. You can choose which one you want, Moderna, Pfizer, or Johnson & Johnson. And it'll tell you where it's in stock and you can book your appointment at that time. So if anyone didn't know where to find it, vaccines.gov or vaccinefinder.org. If I can, I'd like to take a minute to talk about the controversy over the Johnson & Johnson vaccine, because I know that's been in the news. I would like to say that the fact that they saw a problem, they paused dissemination of that vaccine and did the research to find out who was at risk and why is evidence that the process works. So by the time they had paused the Johnson & Johnson vaccine on April 13th, over 7 million people had already received one dose. Again, they paused it because they noticed a handful, and I think anywhere from 6 to 15 was the last number I saw, women developed blood clots. Unfortunately, at least one did die. So I'm not minimizing it, but they were able to find out why. So anyone that is not a woman on hormones between the age of 18 and 50 is not at risk from the blood clots. So that's something to consider. The efficacy is decreased with the Johnson & Johnson vaccine, but you don't have to worry about somebody coming back for a second dose. So it's considered a full series without one dose. So pluses and minuses, benefits, risk, that's what medicine is all about. Does the benefit outweigh the risk? I can say with what we've seen, again, 592,000 people dying in 14 months. For the first time in my lifetime, actually seeing the lifespan decrease instead of increase makes it worth it to me. And I love being able to protect my patients as well. Are there any other questions?
Yes, I did have a question.
Yes.
So I'm not sure. He was in the news for a while. Dr. Carl Hart. He wants to like legalize drugs. I took a class with him in college. But basically in his class, like we just talked about a lot of different aspects of drug use. And like from what I could gather from his class is that like the safest way for people to use drugs is for drugs to be legalized. And then like through legalization for them to be controlled and used safely. So like, for example, we spoke in his class about Portugal, which I'm not sure if they've legalized or simply decriminalized all drugs, but they have like safe needle exchange programs and like people feel safe to like go to hospitals and like to actually like exchange their needles because they don't think that they'll be criminalized for drug use. So I guess I'm just wondering, like, do you think that like drug decriminalization or legalization would lead to better health outcomes in terms of HIV prevention, connected to drug use?
That's a great question. And I think I do remember that professor being in the news. Can I ask you a question? Is he the one who admitted that he used as well?
Yeah, he uses like heroin and other drugs on like a daily basis. Yeah, like to maintain himself. Yeah.
Okay, so strictly looking at the risk of HIV transmission, yes, criminalization would make it safer because we know that's one of the modes is when someone shares a used needle and that's how they can pass it on. If you're looking at the total picture, you do have to look at the problems that those drugs can cause on the human body, impaired decision making, which might put you at risk for additional risky behavior. So it's unfortunately not a one size fits all. I do think there are things that we can do in the meantime. And then again, if you look at previous parts of US history, when you had prohibition and alcohol was illegal and then it was legalized, you can look and see the criminal activity associated with that and how that goes. And then as you add taxation to anything, you can look at cigarettes and how people end up trying to sell what they call loosey-goosies and end up in altercations with police. So it's from purely a transmission standpoint, yes, it would help, but I don't think that's the complete answer.
Okay, thank you.
Oh, no problem. Great question.
I had a question, Doctor. A couple of questions, and they're a bit personal, but I know, knowing you, you're going to be fine with them. Number one is what brought you to work in the HIV field? And the second is, once you got into it, what are some of the things that you discovered that surprised you and that many people don't know about that they need to know?
Oh, great questions. So I will start with the first question first. What brought me to HIV? So again, I'm in my mid to late 30s. I'm going to say that. So I definitely remember those mornings of seeing people die and being afraid. And that even when Magic Johnson was cured, he's not cured. His viral load is undetectable. It just seemed like such a fascinating thing. Like this wasn't here and now it's here. And then seeing the progression of treatment throughout. So the first medication and then the first combined medication of AZT, it was a very interesting area. So that's what initially piqued my interest. Having said that, how I ended up practicing in this field today is because HIV has changed so much. So I'm a family medicine physician by training, which is primary care. HIV is now considered a chronic disease. So 20 years ago, you have to be an infectious disease trained specialist to practice in this area. But because of the advancements, that's no longer the case. So I get to manage my patients' diabetes, high blood pressure, and their HIV. And I'm like, the HIV is not going to be what kills you. It's going to be the uncontrolled diabetes or the uncontrolled high blood pressure that leads to a stroke. So it gives me a chance for patient education. What I discovered about this patient population, it's a very special population. I love working with them. You know, they keep me on my toes. I have longtime survivors that tell me the stories of their partners from 30 years ago, that tell me what it was like to have to take 32 pills a day, and how they're willing to fight and do whatever it has, and they want to see a cure. And you love seeing that passion. I have people that come in tears and crying because they think it's a death sentence, and I get to walk them step by step and see their viral load go from 500,000 to undetectable at less than 20. There are not a lot of parts of medicine that give you that kind of instant satisfaction. Well, not instant, but relatively quick satisfaction. So that's it. It's a very supportive community, and I'm glad to be a part of it.
That's great, thank you. And then one more. When did the JD thing come in? Was that before or after med school?
So let me give you the 90-second spiel. I think I've actually perfected this as an elevator pitch. So I was pre-med in undergrad, became interested in public health, went to the University of South Florida, go Bulls. I know we have a graduate this Saturday. Took a public health course and said, well, if I can change this many patients' lives in the exam room, how many lives can I change through policy and legislation and advocacy? So that's what led to law school. Loved law school. I think the things and topics you discussed in law school, there's nothing else like it. It's like a combination of practicum and strategy with philosophy. So I loved the intellectual experience of law school, not so much the practice. People don't believe it, but I'm really actually shy. And my heart was with medicine. So then I went to medical school and loved the intellectual challenge and getting to interact with people as well. And apparently I just really love school because I am currently in the process of completing my Master of Public Health, which allows me to now officially do the policy piece and the health education piece, which is why I'm before you tonight. I love school, but this is it. I promise, this is it.
Well, thank you very much. And we're so grateful that you've chosen now 3 really professions. So thank you.
But they all interact, and what I love is I'm able to see the interdisciplinary connection between them. I do think it's funny that I'm in a school of public health during a pandemic. You can't make this stuff up.
Right. Yeah.
Can anyone check the chat and let me know if there are any questions there?
See, I don't think we have any.
Okay. Well, I am happy to stay on for a few minutes. I am always going to let people know how they can follow me for tips on health. Yeah, that's that. And then I'd like to say special thank yous, of course, to the Jacksonville Urban League, the Center for Advocacy and Social Justice. The amount of work that you all are doing is amazing. Meharry Medical College, Mayo Clinic, Florida, Columbia Mailman School of Public Health, and of course, those that pay me and allow me to do this, AIDS Healthcare Foundation. Again, in Jacksonville, Florida, you can have testing Wednesday evenings and Saturday mornings at AHF, and any day of the week at the health department. I'm gonna stop sharing my screen at this point and go from there. Hi, President Turner, I love you too.
Okay, I just have one more question, Doctor.
Yeah.
The list that you had on your slides with potential advocacy avenues, they all seem very much on the national level. I was wondering if you could suggest anything on the local level that we could do to try and get this message out there, try to get education out there.
So I would say most of them would probably be at the state level, would be the most local, because you would want to advocate for a change in the law, so that would have to go through the state house. In terms of education, that's something that you could promote at the local level, school board meetings. Comprehensive sexual education doesn't promote sex, it just promotes informed decision making. I know I was working at a public health program several years ago. I don't know how graphic I can get, but a lot of the girls were engaged in not vaginal intercourse because they didn't want to get pregnant, but they were still having unprotected intercourse. So I'll let you guys use your imagination. And it was like, but that's an even higher risk for transmission of HIV. So we have to educate people. If we don't educate people, they're going to educate themselves. And that's how a lot of misinformation gets out. In terms of other things that you can do, and this is a really great question, so thank you. We can advocate to be more inclusive. So when I talk about the transgender rate, transgender people are murdered at a rate that's unimaginable and disproportionate. So we need to tackle patriarchy and toxic masculinity so that when people find out that someone's transgender, they're not afraid. It's no different than anybody else. So of course, the tackling transphobia as well. You know, we have an interesting Supreme Court. It's going to be interesting to see the cases that come out in the new years, especially in the next few years now that we have the 6-3 split. So again, if you want to be with a local advocacy group and submit a brief, that's another option. Making people aware. If everybody goes home or to a friend and says, you know, that you can take medication to keep from getting HIV, that'll be a form of advocacy because you're educating and empowering those around you. Or if you tell somebody, you know what, let's go get tested together. You know, we have people that at 3 o'clock in the morning find the mobile unit and get tested. Those are forms of advocacy as well. They don't seem to be, but they really are because you're empowering and passing knowledge on.
Thank you.
Oh no, my pleasure.
Other questions for Dr. Russ? I was wondering if you see, you know, I've been saying this too often lately, but good things have come out of COVID. A lot of bad things, but some good things. Do you see the opportunity to carry, to rise the level of information in terms of HIV?
Yeah, so I'm sorry.
I was just going to say, sort of restart that information flow.
I think we definitely can. So for 2 reasons. So one, the medium we're using right now. So this is being broadcast on Facebook. I'm sharing it on my Facebook. So that's going to be a way the information can continue to be shared in the near future. But what else this allows us to do is to talk about viruses. So I know when COVID came out and people were trying to understand, what do you mean it's coronavirus, but you're calling it SARS? That gave an opportunity to talk about families of viruses. So we can talk about retroviruses, which include HIV. We can talk about hepatitis, which has common modes of transmission like HIV. So we can talk about those families. So it opens the door for a conversation. Again, you know, just as we've seen with COVID and people having fatigue with following all the protocols, it's the same thing with anything. It's human nature. You can only do something for so long before you're going to revert back to your normal behavioral choices. So this allows us to enter into a new conversation. Again, I think it's fascinating that the science used to produce the COVID vaccine may indeed lead to the cure for HIV. That would be phenomenal. So this again opens the door. I'll ask people to share this so that the information can get out. Because again, if you think about it, 1 in 7. So, you know, right now we have 6 people on the screen. So if we had a 7th, that would be the percentage of people that didn't know they're positive. So you have to keep that in mind. Okay, let me answer this question. If a pregnant person with HIV is on medication at 0 viral load, can they still pass the virus on to their child? No. So that is why it's very important to have adequate prenatal care, to have testing so that pregnant women can find out their status. Children born to HIV positive mothers are tested for the first 2 years of their life to make sure they don't convert. But prenatal antiretroviral therapy will stop the transmission. I love these questions.
Just another question. I'm doing a little Google search. How much of a risk is it now for HIV resistance for the current drugs? I know that the current system is a cocktail, correct?
Yeah, so basically the cocktail has gone from being 32 different pills to being multiple medications in one pill, or I showed you the 2 vials for the injection. Resistance is still very much a threat. So when we talk about people dying from AIDS in the year 2021, it's usually one of two reasons. Either they don't take their medications at all and eventually they succumb to an opportunistic infection, or they take their medications, they stop taking their medications, they mistake their medications, and it leads to resistance. So resistance is when the virus becomes so smart that it mutates and is able to survive the different medications. Resistance can happen in different ways. You can initially acquire a strain that has resistance. So if your partner that gives you HIV had a strain that had resistance, you'll have resistance. You can have a spontaneous mutation. I always say this virus is very smart. It wants to live and it will do what it can, so it will change. Or if you take the medication, you stop taking the medication, you try to stretch out the medication, then what ends up happening is it changes, it mutates in order to be able to survive. So it says, oh, I recognize this, I know how to outlast it. The problem with that is a lot of regimens use similar medications, especially the one pill regimens. They have a similar backbone, so then that kind of blows the whole class and we have to put people on multiple medications again. So how big of a problem is it? It's not as big a problem as it used to be, but again, it's an education piece, making sure people know the importance of taking their medication, because if they don't, then they will be at risk for resistance. Great questions.
Thank you. And I guess, you know, the first step to all that is to just not get infected in the first place, so it doesn't have the opportunity to mutate.
To not get infected, but the safest thing is to get tested so that if you are infected, treatment not only helps you, it helps any potential partners. So prevention is best, and then test and treat is next. Oh, great question. What are the considerations for HIV and aging around healthcare and policy? Great questions. So again, this is just a testament to how fascinating this disease is in terms of the medicine and in terms of policy. So unfortunately, 30 years ago, if someone had HIV, they likely would succumb to it. They were told to get your affairs in order, spend your money, live up your last few days, have a ball. So the benefit of having the medications now are people are living longer. Again, they're getting what we call old people diseases, chronic diseases. I'm counseling them, the HIV is not going to kill you. Your HIV numbers are great. You have to control your cholesterol. You have to control your blood pressure. Heart disease is the #1 killer in America. So in terms of policy, it's important to make sure that we have medications that can interact safely with your cholesterol medications. So one of the medications on the market, it's a great medication, but it has a booster in it, which is great for HIV. It helps the antiretroviral properties work better, but in terms of other medication, it interacts with them and causes side effects. So the drug company came out with a medication very similar, but without the booster. So the way medications are distributed, developed, that's changed. Policy in terms of access. So again, we have the Ryan White program, which is great, but then what happens when a patient reaches the age and they're eligible for Medicare? And then health policy in general has its own issues. Are we going to have a payer for all system? Then you have people that are going to say, well, I don't want to pay for someone who got this because they did something wrong. Again, going back to the stigma. So getting rid of that stigma, having these dialogues is important. Let me see, what are other policy for aging? Making sure that people aren't discriminated against. Unfortunately, it still happens. You want to make sure that people are able to have livelihoods, that they're able to live in the communities of their choices. So those are some other issues that we're seeing now, that we have patients living to be 100 plus, which is very exciting.
So doctor, there's one question here from an anonymous attendee. It says, I had to step away whenever you were discussing positive but undetectable. So do you care to explain that again?
I would love to. Thank you so much. So I'm going to go back a little bit. So when someone's first diagnosed with HIV, I say there are two numbers that you are going to become very, very familiar with: your viral load and your CD4 count. So viral load refers to the amount of virus that's circulating in the body, in the blood at any given time. And then CD4 count, again, that's the blood cell that the virus actually attacks. And when that number drops below 200, people are at increased risk of opportunistic infections and consequences from HIV/AIDS. So viral load we want as low as possible. Under 200 is the magic number. Under 200 for the viral load is considered virally suppressed, but we want it as low as possible. I always tell people, just like a former president said, it depends on the definition of what is. It's the same thing with undetectable. It has two meanings. So it depends on how sensitive your test is. The tests at my job are very sensitive. I can detect any viral load above 20. But in terms of U equals U or undetectable equals untransmittable, it's actually the 200. A viral load under 200 would be considered undetectable because they're looking at all the tests around the world and at what point can we guarantee that the virus won't be transmitted. I do want to point out that undetectable equals untransmittable only applies to sexual activity, not drug use. So I want to make sure people are taking necessary precautions for that as well. So again, you can have the virus, but it can be at such low levels in the blood that we're not able to detect it. And that again is the most famous example of that is Magic Johnson, the basketball player from the early 90s or late 80s, early 90s.
Thank you.
Doctor, just a follow-up for that one. In that case, would a person be able to conceive a child if one partner was undetectable, untransmissible, and the other one was HIV free?
Yeah, so what we call that is we have an HIV positive person and an HIV negative. We call that an HIV discordant couple, and they can conceive. So 20, 30 years ago, they would have done what's called sperm washing. So they would have tested to make sure that the sperm didn't have the virus. They would have done that whole process. Now with U equals U and that knowledge, they don't have to do that. They can conceive and go on to have normal lives. Sometimes people say, well, wait, you're saying you can have a normal life, but I heard you say life expectancy is decreased by 10 years. How is it both? So what I'd like to take one moment to say is that, again, when we talk about viral load, we're measuring the amount of the virus in the blood. There are certain organs in the body that serve as reservoirs, so they actually hold the virus. And the impact on those organs is what leads to the decreased overall life expectancy.
Thank you, Doc.
My pleasure. I am just so thrilled to be able to talk about this with you all. Again, I always say, put me out of business. I want to cure. The whole goal now is ending the epidemic by 2030. So with behavior, with the science we have, and hopefully a cure will be there. But part of it is just making sure we don't let it fall to the wayside. COVID has rightfully so been on the forefront of all of our brains, but everything that was there before COVID is still there as well.
Well, Doctor, we want to thank you for being with us this evening. We appreciate all that you're doing for so many people and your willingness to share information and dedicating the time that you do to so many worthy causes. So we really appreciate it. I also want to thank Anna Yates, who researched this area and was able to put this together and provide some of the questions this evening. I also want to thank our interns, some of whom are with us tonight. I mentioned them earlier, I'll say it again. Anne, and then there's Erica Skipper and Keziah Anderson, and I think Hunter Jones is in the gallery. So thank you everyone for being with us this evening. I want to thank the Jacksonville Urban League, all of the staff and the team there that I work with for the support that the center gets for activities like this, and also the Population Health Consortium that we work with, and the Black Health Professional Collaborative that Dr. Rogers Kane and others are working with us to put together and to support more events like this where we can get important information out to the community. So once again, thank you, Doctor, and thank you all of you for attending. And comment, Doctor?
I'm sorry, just 30 seconds because I saw one last question in the box and I just wanted to address it.
Go ahead.
How can high schools and teachers best take on the mantle of HIV prevention? So what I want to say, full disclaimer, is please follow the guidelines of your school board. While I definitely want people to talk about this, I want people to also keep their jobs. So make sure that you're following those guidelines. The best way to address it is to advocate, or if you can't advocate because it's a conflict and they're your employer, have community organizations advocate for comprehensive sexual education. Knowledge is power. I know, I can't believe it, but my high school reunion that's coming up, we would have teachers that would basically allow us to know that there were things out there And then we needed to do the research on our own. Now with Google, you can basically say, there's this interesting website without necessarily saying, this are the ways you can transmit it. So making sure that you're having people advocate and making sure that people know that the knowledge is out there. Great questions. I'm so excited. Thank you guys.
Thank you again, Doctor.
Anytime. Thank you for the opportunity.
Thank you to all of our attendees. Have a great evening. And this will be on video on our YouTube channel to share with others. So thank you.